and learned audience. Very good evening. This is Dr. Swadesh Ranjan Sarker. Welcome you to my talk on thrombosis in special situation, what to do in a case-based discussion. And we know the different phases of acute DVT treatment. This is an initial phase from the diagnosis to the third weeks, that is 21 days, and primary treatment up to 3 months, and sometimes it may extend up to 6 months. And the secondary prevention or extended phase treatment, it may be indefinite time, and it depends upon the some factors. And these are the drugs for thrombolytic, starting from oral warfarin to the newer novel anticoagulant, that is DUAC. And the scenario one, 32 years of female in second trimester of pregnancy, travels by air for 6 hours, presented with swollen, painful right leg, and no other symptoms. Duplex scan shows acute DVT extending up to common femoral, and what should be the management. So scenario is management of DVT in pregnancy. The enoxaparin injection is only drug approved in pregnancy because it can cross the placenta. And till continue up to the labor, and then shifted to the heparin because of it may be reversed by in case of postpartum hemorrhage. And the another scenario, lactating mother developed acute DVT. So management of DVT in lactation, mainly medical management and compression, and drug of choice is warfarin. In some cases, suppression of lactation may need. And now acute DVT in a patient with high creatinine, that is the management of DVT in chronic kidney diseases. The heparin is the drug of choice because 1.5 to 3 times, and low molecular weight heparin, dalteparin can be used, and the newer guidelines and also FDA approved drugs, that is the apixaban, can be used in case of all stages of CKD. And in a patient with hemorrhagic stroke, what should be the management of DVT? And here there is absolute contraindication of using any anticoagulant and thrombolytic therapy, and IBC filter is the treatment of choice. And another scenario, 75 years male admitted in ICU for urosepsis, and DVT developed in left leg, duplex confirmed the DVT up to common femoral vein, started injection dalteparin, that is the low molecular weight heparin. However, platelets are 80,000 and showing downward trend. So what should be the management? So scenario is thrombosis and thrombocytopenia. The choice of drug is fondaparinux, that is the direct inhibitor, parenteral direct inhibitor of factor 10. And the another scenario, 45 years female with acute thrombotic limb ischemia, taken up for surgery, recent clotting post-op, despite heparin doses, and what should be the management. The scenario is thrombosis in heparin-resistant DVT. So answer is the injection bilirubin only. And scenario 7, patient with carcinoma, prostate on chemotherapy, right leg swelling, duplex shows femoropopliteal DVT extending up to common femoral vein. So question is venous thromboembolism and cancer. So do you initiate and maintain with enoxaparin, warfarin, or DUAC? The recent test guideline recommend DUAC over low molecular weight heparin. And luminal GI malignancies, in case of luminal and urological malignancies, they prefer use of apixaban. And in case of VTN cancer, there is increase. Active cancer causes increased thrombosis and as well as increased major bleeding factors. The initial trials in 2000, they recommend the use of low molecular weight heparin, but the patient compliance by using for long term, that is the very only 37%. So again, there is trials from drugs versus low molecular weight heparin, and they suggest use of low molecular weight heparin, rivaroxaban, apixaban in case of cancer associated venous thrombosis. And so the chest guideline in 2021, they preferred drugs over low molecular weight of heparin. And the question is provoked DVT, the patient with complete 3 months of anticoagulant for DVT associated with orthopedic surgery. Do you stop anticoagulant, continue another 3 months for then reassess and perform thrombophilia skin, then decide. So in case of provoked DVT, that is with transient risk factor, elimination of transient risk factor, chest guideline suggest stop anticoagulant after 3 months. And in case of pulmonary embolism that is discussed earlier, in a patient with pulmonary embolism, 65 years old, showing CTA, there is left pulmonary artery occlusion by thrombus, do you, and vitals are stable, this what we can do? Can we continue by catheter lysis, by systemic lysis, can continue anticoagulation and can anticoagulation and further test. The recommendation is in case of stable patient, continue anticoagulation and do further test. What are these? The echocardiogram and troponin I. If there is RBL enlargement and increased troponin I, the recommendation is anticoagulation and catheter directed thrombolysis. If patient is unstable, then recommendation is systemic lysis. If there is high risk, unstable patient, high risk of bleeding and failed lysis and death is luckily before systemic lysis effective, there is weak recommendation by chest guideline using catheter directed thrombolysis. And again we can memorize this one, and the what should be the reduced dose of anticoagulation, and chest guidelines suggest reduced dose anticoagulation if extending use of anticoagulation, that is rivaroxaban 10 milligram daily and epiaxaban 2.5 milligram twice daily after 3 months of treatment. And from chest guideline we learn venous thromboembolism treatment phase typically 3 months, acute thromboembolism, that is VTE, DVT, anticoagulation of choice is DOAC, extended anticoagulation in case of some persistent factors, and isolated distal leg DVT, that is below the popliteal vein, no need of anticoagulation, only imaging follow-up, and antiphospholipid syndrome with VTE, warfarin lifelong, and VTE with transient risk factor, do not extend anticoagulation. And on conclusion, provoked DVT treatment for only 3 months anticoagulation. Unprovoked DVT, it may need indefinite period of anticoagulation. VTE with active cancer, DOACs are choice over low molecular weight of heparin. Thank you for your patient hearing.
Thank you, Dr. Sarker.